Okay, so we are watching you, and we are here in the panel at the Hyderabad Valve meeting with many cardiologists like Helene Eltchaninoff from the Gran Medical Center, myself, Alain Cribier, and Amit Chaudhary, Dr. Rapolu, Dr. Chandra is here? No, he's not here. No, Chandra is not here. Peter Andreka, okay, here you are, from Hungary, and Dr. I am not sure that I have your right name because many names on the program and not so many people here on the stage. So Dr. Sharo, Dr. Srinivas. Well, we are watching you, Dr. Lorenzo. Can you hear us correctly?
Well, first of all, good morning here in Canary Island and good afternoon for you. Thank you very much to the organization for invitation to participate
well, it's a pleasure.
In this interesting meeting. And of course, to the moderator and the chairperson, especially to Dr. Cribier, that is a really, the father of all of this technology. And in this case, we are going to treat a pure aortic regurgitation in a patient that will be presented the case with one of our colleagues, Dr. Valerón.
Good afternoon, ladies and gentlemen.
Good afternoon.
We are going to present live case 6 in a patient with pure aortic regurgitation that will be performed by Dr. Pedro Martin and Dr. Andres Sanchez. Well, today we are going to transmit live case from the Canary Islands in Spain. We have an 84 years old male with diabetes mellitus type 2, hypertension, coronary artery disease with a stable angina from 2004, where when CABG was performed, left internal mammary artery to circumflex, a right internal mammary artery to LAD and diagonal branch, and a radial artery to a PDA. With preserved left ventricle ejection fraction. He has been followed at outpatient consulting care for moderate severe aortic regurgitation with a New York Heart Association functional class 2-3. Also, the patient has an interstitial pneumopathy with pulmonary fibrosis. The STS was 4.05 and the Euroscore 2, 3.6%. The patient was admitted at the emergency room with shortness of breath and dizziness. The ECG shows second-degree AV block 2-1 at 42 beats per minute, and in the blood test, a glomerular filtration rate of 57, and proBNP was increased. With this situation, a dual-chamber pacemaker was implanted without any incidents. Here we can see the transesophageal echo in 4 chambers view. We can see preserved left ventricle ejection fraction with a severe aortic regurgitation. And short axis shows a proper valve opening without calcium with a central jet. In LVOT, we can see an eccentric jet which is headed to the anterior leaflet of mitral valve, as well in transgastric view. No significant transaortic gradient was obtained with a median gradient of 5 millimeters of mercury. The angiography shows severe distal left main disease with occlusion of marginal branch that fills well from the left mammary graft. In the next image, we can see the occlusion of proximal LAD with collateral circulation to right coronary artery and the right mammary graft anastomosed to LAD and diagonal branch. Finally, angiography shows the occlusion of radial artery graft to PDA. In the arterography, we can see absence of calcium in the aortic annulus with a severe aortic regurgitation with a jet directed toward the mitral valve with preserved ejection fraction. no transaortic gradient was obtained. In the CT angiography, we can see the different measures with an area of 443 millimeters square, with an average annulus diameter of 24.1 millimeters, an eccentricity index of 0.14. Also, we can see the practical absence of calcium with an Agatston score of 269. Also, we can see that the height of left main is 12 millimeters and the right coronary artery is at 18 millimeters. In the abdominal aorta and iliofemoral arteries, we find significant calcification and tortuosity with adequate diameters, as we show. Okay, the table on the right, on the right shows the percentage of oversizing according to the valve size and the amount of contrast that can be applied. In our case, we had doubt between 26 and 27.5, and finally, we decided to implant a 27.5 valve with 2 milliliters less than the nominal volume. We can see here. This slide resumes our experience with MyValve. Median age of our series is 80 years old. We have implanted 131 valves, 3 of them in aortic and pure aortic regurgitation. In relation with valve size, 46% of them has been intermediate sizes, and the pacemaker implantation percentage has been 7.6%. To resume the key points of the case, pure severe aortic regurgitation is a challenging scenario, very low degree of calcification in native aortic valve with an Agatston score of 269, the doubts of the sizing or uncertain valve sizing, the coronary sinus alignment, we should use a two-pigtail technique. In this case, the previous permanent pacemaker allows a deeper implantation, and their issue is the significant calcification and tortuosity in the abdominal aorta and iliofemoral region. So, and now we are going to connect with Dr. Martin, that I think is ready to begin with the live case.
Well, thank you very much for this presentation. You know, I think that very few cardiologists in the world will try to implant a balloon expandable valve in a pure aortic regurgitation with a large annulus. So this is very courageous. And I was just asking the questions about the 32 millimeter MyValve. There is a 32 size that might be further adapted to this kind of situation, which is very challenging, with a large annulus and no calcifications. What do you think about this?
Well, I think that one of the reasons because MyValve and the large sizes exist is in order to treat, you know, an amount of patients with a severe aortic stenosis when the annulus is a big one. But another potential use of this type of valve is to match this type of pathology. Yeah, when the aortic regurgitation is the main problem, and most of the cases is associated with the presence of a larger annulus. So, in our short experience in treating pure aortic regurgitation, as a surprise, not so we haven't found so larger annulus in this type of patient, because we have much pure aortic regurgitation in the previous cases, twice with a 29 millimeter MyValve, another one with a 27.5 millimeter Maibal, and in this case, I hope that we obtain success with a 27.5 millimeter Maibal. Yeah.
Dr. Andreka, would you like to say something about this case? What's your opinion on that? And Helene, maybe if you want to give your...
I just wanted to point out the same thing what you mentioned, that it's very rare that we pick the balloon expandable stent for a pure aortic regurgitation. To be honest to you, in this case, I would have picked a self-expandable valve. And the reason is basically simple, because I can have more on with a retrievable self-expandable valve, because it's in a pure aortic stenosis, the system is definitely not that stable. So I would imagine that there are like points when I need to retrieve the valve, reposition the valve, and put it down again. And if it's a balloon expandable valve, we have just only one chance to put the valve into the proper position.
Sure.
So that's the reason.
Sure. Is somebody wants to say something about this case? What's your opinion? Is it
Jena valve situation?
there is a question about the Jena valve, which has been approved, for treating aortic regurgitation. Do you have any experience with a Jena valve, doctor?
No, this is a good question. Recently, we contacted with the director of the program here in Europe to start a program with Jena valve. They said that due to some restriction in the manufacture of the valve and the production of the valve to match all potential cases that can appear, they are going to start a program here in Spain in the January, February of 2023. And I hope that with that valve we can, we can match, that patient with pure aortic regurgitation and with TAVI. You know that most of the cases can be treated, by surgeon, but not all of them. So I think that there is a hope that the previous results that I know from the European registry are very good. They are trying to decrease the rate of pacemakers in patients that are treated with Jena valve. And I hope that we can this valve can be available here in Spain soon. Another question, yeah. Only one comment, because some of you told about the indication for a self-expandable valve. It's true that sometimes you can feel more comfortable with more opportunity to fix the valve at the really point that you want. But we have experience with core valve, or the Evolut Pro, and more recently with Accurate Neo 2. In this scenario with a good result, but I think that you can treat this type of patient also with a balloon expandable valve.
Okay. Thank you very much, Dr. Lorenzo. And you said also something important, that the patient has a pacemaker in such a way that you are able to implant the valve a little lower. So that's a kind of security, I think, for the balloon expandable. But we will let you do the case because you have half an hour, and so you have some work.
Yeah. We know. Only we want to show what we are doing until now. As was presented, the femoral region is calcified and tortuous, so we decided to change the axis, the main axis, to the left one. I know that you were talking about the minimally invasive technique, but we continue with the conventional approach. So we puncture here where calcium is not so high. So we use as the vascular closure prostate. We feel confidence with that, and we continue with this, obtaining very good results. This is the projection that is recommended by the company. As you can see here, this is all sinus seems to be well aligned, but sometimes in these cases we use double pigtail technique to be sure that the projection is the good one. So here now the second pigtail moves a little bit up, but we are here. So what we do, let's do injection. Here you can see with this technique is what we recommend in all cases for pure aortic regurgitation. So you can check, although with or without contrast, that you are well aligned. So we're going to cross to the aortic valve and put a Safari X wire inside the left ventricle.
I'm sorry, Dr. Lorenzo, is there any chance to have the diastolic pressure of the diastolic gradient between LV and the aorta in the same scale? Is it possible to see that on the screen?
Yeah, you will see now.
And don't you think the aortic leaflets are quite thick?
Yeah.
No? The aortic leaflets are a little thick, so maybe it will help also with the balloon expandable. They are not normal, I mean.
Yeah. No, this is another reason because this case is so challenging. In addition, as you can see clearly, the patient is under conscious sedation, and we demonstrate that we perform all cases under transesophageal echo guidance with no problem related to the patient. The patient looks comfortable only with a light sedation.
Peter, can you hear?
Here, yeah.
Now this, I think, Alain sir was asking
Pedro?
about this. Now, it's 27.5 itself is almost 30% oversize. A balloon expandable valve, which we are selecting here, is 27.5. It's 28 to 30% oversize. Now, obviously, this, in terms of the decision making, I can see there is some calcium now. So having seen the echo, I'm convinced that this will work. But without any thickness or any calcium, with the balloon expandable, as discussion was going on, in a pure aortic regurgitation, I think you have done already 2 cases successfully. Were there similar cases without any calcium with pure aortic regurgitation?
Yeah, similar. The previous cases were more or less similar, and the percentage of oversizing that we decided to select was around 30%. In this case, this particular case, is 28% of oversizing. I think that we have some doubts about what to choose, if 26 millimeter MyVal plus 2 cc or 27.5 minus 2. And after internal discussion with my team, we decided to go for the bigger one with 2 cc less. I know that here, where is not practically calcium present, the risk of rupture is very low. And another comment that I want to do, that some cases that are reported, the most frequent complication is the migration of the valve inside the left ventricle. So here we try to reach at the end, a morphology with no significant waste, but there are moderate waste at the level of the annulus in order to accurate that the valve is clearly fixed at that level.
My other question to you is, obviously, you are going with this valve. What are the additional bailout strategies and additional things you have in the lab? If the valve pops to the LV or valve pops out to the aorta, or if there is other issues, significant paravalvular leak, what are the bailout strategies which is already ready in the lab?
The bailout strategy, maybe we can, if the valve moves inside the left ventricle, maybe we can try to get out with the balloon. If we can't, maybe the cardiac surgeon surgery team is advised of the possible complication.
Yeah, now we're gonna advance the Python. The Python is the sheath of this valve. This is a 14 French introducer that can be expanded until 18 French in order to accommodate the advance of a larger valves.
Hey,
Now we reach the position. How many minutes do we have? Dr. Mutan?
Yeah, till you finish, it seems. We have enough time. So my question to Alain is that this patient has a huge septal bulge. That I think
I'm paying attention now to that. Yeah, I know.
That's a concern for a balloon expandable valve versus a self-expandable valve. I think the balloon expandable valve has a higher chance of embolization with the septal bulge that is there, you know.
Yeah, in order to try to avoid that, as you can see in a few minutes, we're going to inflate the valve, you know, a bit slowly in comparison with a conventional approach. And after that, it's very important to reduce rate pacing, you know, slowly, you know, from 180 to go down to 150, then 120, until you obtain a normal heart rate. Yeah, I think that for us is a key point there. Now what we do always with this type of valve in order to facilitate the advance of the 7.5 millimeter valve is just before to advance the valve, we advance the 18 French introducer to make more room to the valve. As you know, this valve, this is a unique expandable valve that can be pulled back through the introducer once it has been inside previously in the body.
If I can just interrupt you just a minute to say that bulging septum, you know, has been considered a contraindication to a balloon expandable valve at the beginning, but in fact, we had to demonstrate that the gradient, the subvalvular gradient created by the bulging septum was in the range of 20 millimeter of mercury to create a danger of embolization. So did you have, by chance, did you measure by echo the gradient, the subvalvular gradient in this patient? Do you have any idea?
There is not subvalvular gradient in this case. It's there's no gradient, as you can see in the slide before. And here I can demonstrate better. Gradient. 1 second, maybe Dr. Quevedo can go to the transelastic view in order to obtain a gradient. It's not easy here, but we check in a transthoracic one, it's no gradient at all, no subvalvular gradient. Now here, you can see, we introduce the valve. As you can see here, at the beginning, we don't find resistance. Yeah. Let's show the advance of the valve inside the introducer. You see the gradient there? Here we only check the position of the valve. One comment only about the valve. Look at it's advancing inside the tortuous and, as you can see here, very calcified, but big artery. Here you can see how the valve abandoned the introducer. Here, come on. Duro, tensa. Find any difficult here? Yeah. And then now we move to the position.
What's quite remarkable with the valve is that you can use a 14 French introducer, you know, for any kind of valve size, you know, even 27.5. So this is something interesting.
Yeah. With this, you see clearly how easy pigtail goes into the. Yeah. Well, let's correct the position of the pigtail. Here. Deja 10. We're almost ready to go for implantation. 1 second. Okay. Okay, I will make some comment about the ideal position of the valve. Colimador fuera. As you can see here, un mini test. Un poquito más necesito.
Excuse me, but how are you planning to do the rapid pacing? Are you pacing on the gadoir?
No. No. Almost, in this case, we have a transitory electrode, in the right ventricle. You see, in parallel of the permanent one, we have another. ¿Sale?
So
okay. You see, we're gonna do external pacemaker, yeah? So, here, parallel, stop. Haz un zoom. Play. As you know, with MyVal, in severe aortic stenosis, the aim is to go for 20% of the valve in the aortic plane, in the 20% or 15% in the ventricular side. So, as a marker, you can use the second dense band located starting from the left ventricle. As you can see, this is below of the central marker of the balloon. There is a dense band that is what you have to put at the level of the aortic annulus. Here, as we commented before, this is another scenario where we have to be, to accurate more the implantation. We are going practically in this position, okay? And also in this case, the presence of the permanent pacemaker allow us to go deeper with implantation, okay? So first of all, we are going to start pacemaker, and only to know or to anticipate what is the unexpected movement of the valve. It's only a test. Then, if the valve looks to be stable there, we will start slowly in order to modify, very slightly the final position to go until the end. Once there, we will keep there during 5 seconds with 180 beats per minute. And then after the implantation, we will decrease the pacemaker rate slowly, okay? So, go on. Venga, lo tenemos claro, ¿vale? Una prueba primero, okay?
Pacemaker?
Only, transitory pacemaker. Let's see. Okay, the valve looks stable there. Okay, stop. Espacio para seguir tunear. Okay. New flash. Okay.
Can you repeat what was the pacing rate that you selected? I guess that
180. 180 for the beginning.
180.
Okay?
Well, you don't think that in case of aortic regurgitation, you better use a pacing rate as fast as possible just to to improve the chance of having the stent staying in place, during the balloon inflation. It might be, for example, 200 or 220 or something like this, in this particular case. But I don't know. This is just a question.
Yeah, maybe. Yeah. Yeah, for all of us, the perfect condition will be that the patient will be in a cardiac arrest, transitory, yeah? But it's not possible. So maybe I think that it's okay. It's a good comment to increase to 200, but in this case, we cannot, with the stimulator that we have, we can reach a tope, 200, ¿vale? ¿Puedes, 200? Venga. No se puede, ¿verdad? Ok. Come on, para, venga. Check again.
Vamos un poquito, ¿no?
Sí, un poquito. Pero, no, Leo, stop. Quieto. El último movimiento dice para atrás, porque si no se sale. ¿Ok? Quieto. Test. ¿Sí? Quieto. Venga, que no se meta, ¿vale? Que no se meta. Tranquilidad. Pacing. Vamos. Flash. Vale. Flash. Venga, arriba, Andrea. Quieto. Arriba, Andrea. Vale, 150. Empieza a descender. 120. Vale. 100. A ver, Pedro. Para. Vale, ok. Es intravale. Stop pacing. Venga. Nos vamos. As you can see in the transesophageal echo, I can see a signal of intra-aortic, intravalvular leak. This is maybe related to the position of the wire. As you can see there, pay attention to the transesophageal echo. There is no residual aortic regurgitation there. You can see. I think that the position in this case, as I told you before, is going to be a bit deeper than in other cases. So we're going to pull back the balloon. Now the blood pressure should increase, little by little, and I think that there is a very nice final result, demonstrating that if you have, clear a few concepts, you can treat pure aortic regurgitation with balloon expandable valve. In this case, as you can see here, I will show the valve looks, well expanded, no very significant waste at the level of the aortic annulus, and I think that this demonstrates that the sizing is good.
I think this is time to congratulate you, because the result is very good. To be honest to you, I was a bit worried. What
I know.
But you did a great job, a really, really great job. This case was very challenging. It was definitely off-label procedure, but sometimes we have to do off-label procedures if there is no any other chance for the patient. Because of the regurg, because of the very small amount of calcium, because of the bulging septum, it was a very, very difficult case. So congratulations, and the result is great.
Yeah.
I just would like to
only
add
comment. Thank you very much.
My feeling, that you are very courageous, and it was very demonstrative and very instructive to see that even with a very, very small gradient, if any, if you have a major regurgitation, you can implant a balloon expandable valve, and especially the my valve, which is particularly adapted with a 27.5 millimeter in diameter. So this is a great demonstration. Thank you so much.
You're welcome.
There's a hall full of people holding their breath.
Yeah,
I think
one
you
second
need
to perform a final
you need a big
angiography.
applause from all of us all.
Give me a wire to put back the time. And you know, thank you for the comment about
will you do an
this is
angio
a
to
clear
finish
of
it?
label. This is a clear of label case.
You want to perform an angio?
You have time to
Is it
do an
possible?
angio. It would be interesting to do a supraaortic angio, no?
Yeah.
Yeah. Okay.
You know, when Dr. Cribier decided to start with TAVI, was a very off-label situation. And look at the final result.
Is there any risk of late embolization? Late embolization?
Wait, this is
So next there is a question about the risk of late embolization. I don't think so, but do you have any specific idea on that?
In our experience, there's no case of late embolization because as you can see, this is the valve looks very stable there.
You can remove the
Yeah.
detail.
No. Let's check the gradient. Go ahead. Tira, sácala bien, vamos a ir directo. Se va al cuello. No, okay. Okay. Final.
We are going to perform an gradient, a transvalvular gradient, and then we perform the angiography.
Yeah, only 1 minute more, please. Pero qué tal? I'm asking our, colleague of ECHO about the result. She looks very happy. So.
Pedro? ¿Era una aorta? Okay.
Professor Cribier, what is your experience with the pure aortic regurg?
Actually, we have been doing 2 cases.
Zero?
But the problem is definition of pure aortic regurgitation. If you have some fibrosis on the leaflets, if there is a small gradient, it's not really a pure aortic regurgitation. It's a aortic disease with a major aortic regurgitation. But if you don't have any calcium, if you don't have any fibrosis, I think the risk of embolization of the valve remains relatively high. But well, maybe with the Jena valve, I don't know if they have been approved for that. So maybe they have everything is coming from definition of pure aortic regurgitation. Do you have an experience yourself?
We did some. I used only self-expandable valves, not balloon expandable ones. But I can tell you approximately the same thing, that the definition is very, very important and the pure is not pure. Yeah, which is true. And let me have another question. We got a question from the audience, but I don't remember whether we had a chance to reply. So if you had been the operator, what would you have done if you had experienced embolization on the table during this case? I'm just wondering, what bailout techniques would you have?
Actually, it's a real problem.
There's a pretty high chance in a situation like that.
Yeah, maybe we can ask Dr. Lorenzo to answer these questions. What would have been your strategy in case you had an embolization of this valve? Are you calling the surgeon or? Well, I guess that the embolization would be in the aorta, not in the left ventricle. But if the embolization is in the aorta, can you try to remove the valve and to block it in the descending aorta, for example, and to forget about redoing it again or sending the patient to surgery? I don't know exactly. If the valve.
Oh no, of course, if embolization occur to the aorta, I think that is a most significant sign that the case is not able to be treated with this type of valve. In my experience, in this type of cases, we have not that problem, but if it will appear, maybe after to put the MyVal in another region of the aorta, maybe we can go with a self-expandable valve. But I have been talking about this type of problem with Dr. Amat, that I see that is coming later to have a speech. And then, during the implantation, it is more dangerous that the possibility of the valve to embolize to the left ventricle. In that case, I think that the best strategy is to send the patient to surgery and solve the problem. They can pull back the valve and they can fix the aortic rotation, put in a biological prosthesis. So
we can check the transvalvular gradient is peak to peak.
I think I am sorry, Dr.
You see the
Lorenzo.
gradient, yeah? No gradient, and the diastolic
We believe that
pressure is very nice.
you won't see any supraortic. If you do a supraortic angio, you won't have any aortic regurgitation because the diastolic pressure of the aorta is good. Because unfortunately we have to leave you here because we have the program. We are late on the program, and there is the gala opening very soon. So. I think you can thank you a lot, and congratulate you again for the way you have been managing this case.
Final angio.
I want to perform the final angio.
Yeah. Go.
Okay.
Go on. Okay.
Thank you, professors, and thank you, gentlemen.
Yeah, here.
Next, we go for a Zoom talk from Spain.